So this is what is malnutrition. WHO, what's the definition of malnutrition? Malnutrition is defined as the cellular imbalance between supply of nutrients and energy and the body's demand for them. So whatever the body is demanding of the energy and nutrients, that nutrition we are not able to give. And that is needed for ensuring growth, maintenance and specific body functions. So malnutrition occurs when the body does not get the enough nutrients and energy and to maintain healthy tissues and organ function. Okay, so this is the broad definition of malnutrition. Now, next, Akash. Okay. So you have a big spectrum of protein-energy malnutrition. You have protein-energy malnutrition. It is from mild to very severe forms. The severe forms are Marasmus and Kwashiorkor. Okay, we'll be discussing that also. But you look at the mild forms. Fortunately, we don't have that many Marasmus and Kwashiorkor cases now in India, or for that matter in the world, except in Africa, places like Africa. But many years back, during the final MBBS exams, one case would definitely be there in pediatrics, which would be a case of either Kwashiorkor or Marasmus. So, protein-energy nutrition is a group of body depletion disorders which include Kwashiorkor, Marasmus and the intermediate stages. So what exactly are we talking about? Next. So this is the general term. PEM is the general term for all cases of protein-energy malnutrition, and it extends from mild cases right to the extremes like Kwashiorkor and Marasmus. It's a major health problem in India. Major health problem meaning malnutrition is a health problem. Kwashiorkor and Marasmus, as I said, is not much seen now these days. You will hardly see it in India thanks to various programs which we have been doing over the years, like improving nutrition of children, etc. And this is common in children younger than 5 years. For it. Now, this is some pictures of from the various WHO sites, UNICEF site and all. So this was the prevalence of malnutrition in India between 2005 to 2006. So as you can see, that red area, that is the place where malnutrition was there about 20 years back. That is basically the central India, Madhya Pradesh, Chhattisgarh, Jharkhand, Bihar, etc. This is from between 2005 to 2006. Next. Now, this is a progressive report based on National Family Health Survey, NFHS data. So, NFHS data was done 2005, 2015 and 2019. Now, if you look at the first part, stunting, I'll explain stunting shortly. Stunting has decreased from 43 in 2005 to 38 in 2015 to 35 in 2019. Okay, the term stunting that was there very high, it was 43, became 38, it became 35. The next one is wasting. These two terms are very important, we will discuss that. Wasting was 20, it went to 22 in 2015. Again, it's gone back to 20 in 2019. Wasting is more or less static at 20 as per the NFHS data. Underweight, the number of underweights have gone down from 38 to 36 to 31. Overweight on the other hand has increased. Okay. So we are talking basically about, of course, overweight is also a nutritional problem, but we are talking about the first three. That is stunting, wasting and underweight. So if you look at this side, trending in, you will not see it from there. Look, if you look at the areas where stunting improved, Sikkim, Rajasthan, Uttarakhand, Haryana and Madhya Pradesh. Here the stunting has improved. Okay. They were bad in 2011 and 15, but in 2021 they have improved. But on the other hand, smaller states like Tripura, Lakshadweep, Goa, Himachal Pradesh, Telangana, it has worsened. Okay. So uniformly there has not been a great improvement. It improved in certain states, but it became bad in certain states like Tripura, Lakshadweep, Goa, Himachal Pradesh and Telangana. Next. Now if you look again at the district levels where the stunting improved, Bhopal, Madhya Pradesh, Balrampur in UP, Rajnandangao in Chhattisgarh, Tikamgarh, Madhya Pradesh, Siddharth Nagar in UP. On the other hand, Kulu as in Kulu Manali, Himachal, then South Garo Hills, that is in Meghalaya, Mahi in Pondicherry, and Dhalai is Tripura, Tumkur in Karnataka. These places again they have shown the stunting has worsened. Okay. So if you look at the maps, you can more or less visible. Next. Again, wasting. Wasting it is improved in Pondicherry, Haryana, Uttarakhand, Madhya Pradesh and Jharkhand. But it is again Ladakh, Nagaland, Jammu and Kashmir, Telangana and Assam, it has become worse. So uniformly, there is no uniformity in this. Some places they have increased, some states they have decreased. Next. So again, if you look at wasting, it is improved in Tehri Garhwal in Uttarakhand, Uttarkashi, Ambala, South Garo Hills and Gadag in Karnataka. But here in Assam, Karimganj, Shopian, Jammu and Kashmir, Shihor, Bihar, Gandarbal again, Jammu and Kashmir, Kupwara. These districts it has worsened. So wasting has worsened in these districts. Now if you look at trends in underweight, it is improved in Madhya Pradesh, Haryana, Puducherry, Pondicherry, Jharkhand and Rajasthan. But again Nagaland, Himachal, Telangana, Jammu and Kashmir, Dadra and Nagar Haveli. So a small pattern is there. The pattern is smaller states, they have not improved that much, either because of lack of political will or whatever, or maybe the infrastructure is not ready. They form state, but the health department and those things are still not in place. So again, underweight among children, 2015, Dungarpur in Rajasthan, Tehri Garhwal in Uttarakhand, Pratapgarh in Rajasthan, Ambala and Guna. These all improved. Nagaland, Zunbita, Shopian in Jammu and Kashmir, Mahi, Anantnag, Karimganj. Again, it has worsened. This is for underweight, mind you. Okay, not stunting, not wasting for it. Now, this is important thing. In 2019-21, the prevalence of child stunting was 30% in 22 out of 36 states. About 36% in 22 out of 36. That means almost 75%. It was about stunting, and child wasting was about 10% in, about 20% in 10 states. Child underweight was about 30% in 12 states. Then the others are the overweight prevalence. Overweight, we are not talking about those. But this is the first three are important as far as we are concerned. Child wasting in 10 states. Child underweight was about 30% in 12 states. The prevalence of child stunting was about 30% in 22 out of 36 states. So this is the fact is that we are still having problems. Okay, it is not fully clear as yet for it. So this is for multiple agencies from UNICEF, WHO, various agencies. They've come to an average that 18.7% child wasting rate is there in India. Okay, this is as per the UNICEF data. Next. Now, what is stunting? Height as below what is expected for age. Okay. So obviously, when you have all 5 fingers are not the same. One finger is bigger, and similarly, you don't expect everybody to be the same height. Okay. So if those of you who follow cricket or who know a bit of cricket about the past, there was a cricketer called from West Indies called Joel Garner. His height was 6 feet 7 inches. He was a bowler, and he used to bowl to Sunil Gavaskar, whose height was 5 feet 1 inch. So when the ball would come, it would just rise above Sunil Gavaskar's head, and he would duck. Those days there was no helmet or protective gear. So he was the tallest cricketer those times, and Gavaskar was probably the shortest cricketer. So I mean of those times. So what I'm trying to say is there's no standard, but the formula is that height below what is expected of age. So as per the certain age, you expect a certain height. So, but there's another thing, child under 5 whose Z score falls below 2 standard deviations of median height for age as per WHO growth chart. So WHO has formed a growth chart in which there's something called standard deviation, and if the weight falls below what is expected of 2 of the standard deviation, then 2 standard deviations, then we consider it as significant for it. Now look at this thing. This is a normal curve in statistics. Now for example, I'll give you a small example. You're all first years, right? So you joined MBBS in the year 2023, right? Sorry, 24. So the average age of yours would be 18 or 19 maybe. Okay. So if you look at that, the 18 would be the average age. That would be the center point probably. And maybe somebody is there who's 17, somebody who's there who's maybe 20, 21, okay. So this is the maximum of cases of your age would fit into these groups, right? So this is one standard deviation, this is two standard deviations. Now suppose you have somebody over here, you cannot have somebody over here because the criteria for NEET is that you must complete 17 years. But this side, if you have somebody who say 25 years, there's no upper limit for NEET, somebody is joined after BSc, MSc or whatever, then obviously he's coming under this standard deviation, more than 3 standard deviations. So majority of cases fall in the 2 standard deviations. Do you follow this? Have you followed this part? Majority of cases in any normal curve falls under this 2 standard deviations for it. So this is what I was telling you. 68% of data falls under the first category. 95% comes under within 2 standard deviations. So 95% of your height or weight of this particular batch should come in that 2. Now if somebody is very overweight or very tall, then obviously he will come under the more than beyond 3 deviations. So that is what is this data. Okay, is this clear? This part of statistics is, I don't think it has been taught to you, but this is a basic thing. Whenever you make a group and you make a median or some middle point, all the other values will be in a sort of bell-shaped curve if it's a normal distribution. Majority of the cases, 68% will fall within 1 standard deviation. 95% of cases will fall in 2 standard deviations. 99.7 will fall under 3 standard deviations. Anything beyond that is considered as an aberration or abnormal for it. So this is the formula to calculate Z score. Z is equal to x minus mu divided by delta, where Z is equal to Z score. X is value of the element, mu is population mean, and sigma is the population standard deviation. Now I'll give you an example. Don't get confused at this, seeing this thing. Everything is there in the book for it. Now let's take an example. You're going to give an exam, and the exam total score is 500. The mean score, you scored 500, and the mean score, the average score is 390, and the standard deviation is 45. So using the Z score formula, Z is equal to x minus mu divided by sigma. So 500 is your score minus 390. 390 is the average score. Your score minus the average score divided by the standard deviation, which is 45 in this case. So you get the Z score, which is equal to 2.44, which means your Z score is 2.44, indicating your score is 2.44 standard deviations above the mean. So let's assume that for the purpose of argument, you're applying for NEET exam. If your score is like this, you are 2.44 standard deviations above the mean. But on the other hand, if your score is say 300 or 200, 300 or 200, then obviously what happens? 500 minus 300, 300 minus 90 it becomes. 300 minus 390 divided by 45. So 300 minus 390 is minus 90 divided by 45. So you get a Z score of minus 2. Suppose your score is say 270. 270 minus 390 divided by 45, that's how much? So that becomes minus 3, more than 3 standard deviation, which means you don't have a chance to qualify, get it. So it's not what you get, but how much is the average. So based on that is the same Z score. Is this clear? Or am I going too fast? Is this clear to you? Huh? Yes or no? Tell me loudly, then I only can proceed. Because this is the example of the exam is important, because here you have got 2.44, which means your score is 2.44 standard deviations above the mean. But if it is below 2 standard, if it is less, which means that you will not be able to qualify for the exam. Okay, so that is the meaning of Z score for it. So the WHO says that defines stunting as a height for age that is more than 2 standard deviations below the median of the WHO child growth standards. Okay, so you have a growth standards below 2 standard deviations, up to 2 standard deviations acceptable. Obviously, an American child and an African child, the growth may not be the same, or an Indian child. So up to 2 standards deviation, it's acceptable. Beyond that, we consider it as stunting. Okay. Stunting means the height, person's short height, whatever it is, the child is short height. Next. And wasting is again 2 standard deviations below the expected weight for the height. So if you have somebody whose weight is so much and the height, there are charts for weight and height. So expected height, the expected height, you must have an expected weight. Here also, if it is below 2 standard deviations, then it's considered as wasting. Okay. Now, I'll show you some pictures, we'll be clear about it. So, you have severe acute malnutrition, is also called SAM. Here you have edematous. Remember, edematous word is Kwashiorkor. During our time also, we used to get confused between Kwashiorkor and Marasmus. Remember, Kwashiorkor has got the letter O. O for edema. Okay. Marasmus, there's no edema. That's the main difference. Severe wasting is there in Marasmus. And marasmic Kwashiorkor has got features of both Marasmus and Kwashiorkor. Okay. But this is just now for academic purposes because the question may come, but you will not get to see a case. Very rarely you will get to see a case of Marasmus or Kwashiorkor in India now. Next. Now, here it is a leading cause of mortality and morbidity. It was. And the main problem is that a malnourished child is susceptible to infectious diseases. And in India and Africa, it's very high. India, it's become less now thanks to various schemes like Anganwadi, we have food being given in Anganwadis, iron, folic acid supplementation, etc. And 30 to 40% children have this is for have this age under 5 years, and 7.6 have severe malnutrition for it. So, what are the causes for malnutrition? There may be plenty of causes, medical, social, many causes. First is children between 6 months to 5 years at most at risk. Why 6 months? Till 6 months, if the child is breastfed, the child should have a normal growth. After 6 months, once weaning starts, then the problem starts, and then till 5 years, the child may be malnourished. And it's common in boys, and other factors include too many children in the same family. If suppose there are 2 children in short spacing, the mother can't breastfeed the child. Lack of spacing between children, low birth weight baby, twin and multiple births, poor growth in the first few months, mother's failure to breastfeed baby because she is unaware, or there's no production of milk, or she's got a breast abscess or breast infection or something, and systemic disorders or gastrointestinal structural disorders. Okay. Now this is very important because the child will never be able to say that I've got a tummy upset or something like that. So the mother has to assess it. So mother may not be aware about this. The mother may, or she's not educated, or she doesn't have any knowledge, then she may not be aware of it for it. Then again, failure or stoppage of breastfeeding. Sometimes what happens is in the rural areas, the child has got a fever, somebody says stop breastfeeding, and the child is, breastfeeding gives you a lot of nutrients, but the child is not breastfed. So that again leads to a malnutrition. So it's a vicious cycle. Infection, malnutrition, again infection. Then delay in weaning. Instead of, usually weaning is started at 6 months, giving artificial food, but sometimes it goes beyond that, 9 months, 10 months, whatever. So that is again a major problem. The child is not exposed to outside food. Then infectious diseases like diarrhea, acute respiratory infections, which are very common, measles. Then you also have chronic diseases and congenital disorders. Then there's failure to thrive for various reasons. There may be endocrine disorders, then also coronary heart disease, growth retardation, lack of adequate care for the pregnant women, and acute illness or surgery. So these are all various factors which are responsible for malnutrition. Again, low birth weight, multiple births, not breastfed, high birth order. So if the child is the last in, say, 4 or 5 children, the child is likely to get neglected. Congenital defects, poor socioeconomic background, single parents, orphans, foster homes, maternal deprivation. If the mother is no more, then the child can be malnourished. Next. So you have 3 categories basically: mild PEM, moderate PEM, and severe PEM. Mild PEM weight is below third percentile, but above the three standard deviations. So the growth, there's a growth chart, it tends to point downwards. Second one is moderate, which is equal to or below three standard deviations, but above the fourth standard deviation. Here there is no edema or skin changes, and the appetite is also normal. So here it has not reached the stage when it's very severe. In severe PM, the weight is below 4 standard deviations, and here severe PM includes Marasmus and Kwashiorkor. So the first one is mild PM, the weight is below third percentile, but above 3 standard deviations. Growth flat chart, it tends to go downwards. Then you have moderate one, which is below 3 standard but above within the 4th standard deviation. Here there is no edema, skin changes, child is alert and appetite is normal. Severe ones, you have Marasmus and Kwashiorkor, weight is equal to or below the 4 standard deviations. So here, this is what we talked about: stunting, underweight and wasting, 3 terms. We already talked about them, just putting them in a proper way for it. So stunting is height for age below 2 standard deviations from median age given in NCHS reference population. NCHS is National Center for Health Statistics, as in USA. Underweight, if the child is 2 standard deviations below for median weight for age given in NCHS. Wasting is if the child is weight for height, mind you, weight for height, not weight for age. Weight for height is below 2 standard deviations, that is called wasting. So weight for height, that is the criteria, not weight for age, that is wasting. That is, the first one is height for age. Stunting is height for age, wasting is weight for height. Okay. So just remember these 2 terms, stunting and wasting. Stunting, you are seeing a small child, child which is shorter than his peers. Wasting, the child's legs and muscles and all you can thin and sort of thing. Next. So again you can, this is again this is the IAP classification. IAP means Indian Academy of Pediatricians. Normal means more than 80% of the expected weight is normal. Grade 1 malnutrition is the child has got 71 to 80% of the expected weight, that is considered as normal. Grade 3 is 51 to 60% that is severe malnutrition, and grade 4 is, if it is less than 50%, it is considered as very severe malnutrition. Okay, this is the Indian Academy of Pediatrician classification for it. So the same thing, more than 4, grade 1, grade 2, grade 3, grade 4. Grade 4 is less than 50% of the expected weight, that is called very severe malnutrition. Weight for age, okay. So if a 1-year-old child, 2-year-old child has got so much weight, standard weight, and less than 50% of that, say if a 2-year-old child is there and the child has got a weight of 1 kg, it is less than 50% expected weight. So that will be a case of grade 4 malnutrition, or it will probably go into Kwashiorkor or Marasmus. Next. So then you have another classification which is again confusing. You will learn more in your pediatrics as well as your when you go to 3rd year. It's called Wellcome classification. Here again they are looking at weight for age. If it is 60 to 80%, it's undernourished, but edema is absent. 60 to 80% again, if edema is present and undernourished, it's called Kwashiorkor. Remember the letter O is then Kwashiorkor, letter O is also then edema. If it is less than 60%, it is Marasmus. There is no edema in Marasmus. Marasmic Kwashiorkor, there is edema. So you have a combination of Marasmus and Kwashiorkor, which is called Marasmic Kwashiorkor, in which there is edema. Next. This is Gomes classification, another slightly confusing as for your age. Here 90 weight of the child divided by weight of normal child of the same age into 100. So grade 1 is 90 to 75% normal weight. Grade 2 is 75 to 60% expected weight. Grade 3 is 60% of expected weight. Here they are not looking at the age. Next, for it. So here only weight for age, they're not talking about the height. Okay, they are only looking at the weight for age, not the height. So that way Gomez classification has got a problem. They are not commenting about the height, and all cases of edema and third degree irrespective of weight for age. So we normally follow the IAP classification or the Wellcome classification. Gomez classification is there in the textbooks, but it's not used much because there is no comment about the height. They are only taking weight for age, that's all. No comment about the height. Next. So nutritional, if it is more than 90%, it's considered as normal. First degree is 75 to 90, second degree is considered between 60 to 75, third degree is below 60. So syndromal classification, so far we talked about percentages, severity, etc. You have syndromic stuff, we have Kwashiorkor, nutritional marasmus, pre-Kwashiorkor, nutritional dwarfing. Next. Now Kwashiorkor, now this was first described by somebody called the name of Cecily Williams, and in 1933, and the term was described in 1935, and it was considered red boy. Okay, it's in Swahili language, in African language, it's considered that it translates as red boy due to pigmentary changes, and mainly found in preschool children and sometimes at any age, and infection precipitates. Okay, so deficient here in Kwashiorkor, there's a deficiency of both protein and calories. Proteins are more predominant. There's more proteins, protein deficiency is much more than calorie deficiency. But there are clinical features are coming. So here you look at the essential features. There is marked growth retardation, muscle wasting is there, psychomotor changes are there, pitting edema is there. Remember, the pitting edema is a classical sign of Kwashiorkor. Then non-essential things are hair change, which is also called the flag sign, skin changes, and superadded infection. Now, if you look at the pointer, if you go slide. So if you look at the hair changes, you will find the the hair has changed. Apathy, the child is irritable. Muscle wasting is there, you can almost see the bones. Fatty liver is there. There is villous atrophy of small intestine. Depigmentation of skin, you can see in the right thigh. Edema, and that's very important, and dermatosis. So all these are features of Kwashiorkor. And just look at the stomach. The stomach is bulging, the abdomen is bulging. Okay. This is a drawing. We will come to the actual picture later on for it. So here again there is a grading of Kwashiorkor just for academic purposes. Grade 1 is pedal edema, grade 2 is edema plus facial puffiness, grade 3 is edema of the chest wall and the paraspinal area, and grade 4 is all this plus ascites for it. So Marasmus is, on the other hand, is also called infantile atrophy, and there is a deficient intake of both protein and calories. And here marasmic person looks like an old person. Those of you who have seen the film Pa, you have seen Pa, I'm starring Amitabh Bachchan. So if you look at that picture of Amitabh Bachchan, the child looks like an old person with wizened and shriveled face due to loss of buccal pad of fat. And here the child is irritable, hungry, and wants food, craves for food. Later on, the child becomes apathetic and refuses food. So initially the child has got an appetite. So here again there is marked growth retardation, muscle wasting, marked stunting, and absence of edema. There is no edema. Okay. Non-essential again, hair change, skin changes, dry, scaly, liver is shrunk, but the child wants food. The child wants food. The child cries for food. Psychomotor changes, mineral deficiency. So if you look at the face, the hair may be normal, old man's face, anxious look, thin muscles, thin fat, but there is no edema at all. Okay. So this is a comparison. Here left side is Kwashiorkor, scaly skin, distended abdomen, swollen ankles. The right side on is Marasmus. You have an old person's face, wrinkled skin, hair loss, and there is no severe, but there is no edema. Here you have a slightly fatty, the abdomen is bulging. This is the difference between Kwashiorkor and Marasmus. Remember edema, we're starting with O. Right. So this is a basic difference in Kwashiorkor and Marasmus is this. Kwashiorkor develops in children whose diet are deficient in protein. Marasmus due to both protein and calories. And here it's 6 months to 3 years is Kwashiorkor. Marasmus is usually within 1 year of age. In Marasmus, subcutaneous fat is not preserved. Kwashiorkor, there is fat. Edema is present in Kwashiorkor. Enlarged liver is present in Kwashiorkor. Ribs are not very prominent. Okay, the child, you don't see so much wasting as you expected. The child is lethargic in Kwashiorkor, but in Marasmus, the child is very alert and irritable. Muscle wasting is mild or absent in Kwashiorkor. Severe muscle wasting in Marasmus. Poor appetite in Kwashiorkor. Marasmus, though the child is very malnourished, the child is a voracious appetite for return. So then how do you assess the Kwashiorkor Marasmus when you get a case of protein energy malnutrition? You have to go through, how do you, first is do a nutritional assessment. You take the history, take the clinical findings and try to get a 24-hour retrospective dietary recall. It's not very easy. If the child is breastfed, it becomes easy, but otherwise, what all the food had in the past 24 hours, the mother should be able to say. Societal and environmental assessment. What sort of society is this person staying in? What about the family, the local people, the area, etc. The growth chart and anthropometric measurements and compare with the population standards. So growth chart is another important thing which I'll be discussing the growth chart shortly. Next. So management of PEM is you have multidisciplinary approach. You cannot give it just one shot medicines or something. You need a lot of things. In fact, even a few years back, we had malnutrition corners in many medical state government hospitals and medical colleges. So where people would get there and the child would be brought with the mother, and along with the treatment, the mother would be given health talks, the mother would be given booklets, etc. So aim is to supply what has been lacking in diet and to help to prevent and treat infections and to teach parents how to prevent relapse. So here, once you give the medicines, again, there's a chance of relapse. So you have to teach the mother that what are the warning signs, and the child should not have a relapse at all. So you can domiciliary management. If the child has got mild PEM, you can do it manage at home. Parents educated about this. Nutritional counseling. You don't have to have, say, every day you don't need to have chicken biryani or something like that. You can go less expensive, locally available food. Community support system, if there are ASHA workers, Anganwadi workers, or somebody else comes and comes to help. Then home visits and medical follow-up. Medical follow-up, the most important thing is home monitoring. Has the child's weight gained after all the advice or treatment? Management in hospital. In advanced cases, there's no other way but to go to hospital. So here, in mild PM, you rule out infections. Whether the child has got diarrhea, the child has got acute respiratory infections. Then again, provide nutritional counseling to the parents. As I said, tell them to give good nutrition food, cheap food. You don't have to go for very expensive food. Whatever is available, you can make a nutritious food with that. Replace nutrients and breastfeed till 2 years with the introduction of supplementary food at 4 to 5 months. Immunization, this is another important thing. Normally, if somebody has got a fever, the mother will say, okay, let us postpone the immunization or stop breastfeeding. These are the two practices which actually increase the problems. If the breastfeeding is stopped or the vaccination is not given, vaccine should be given. Suppose the vaccine can't be given today, give it tomorrow. Give it next week, but do give it. So immunization is very important along with breastfeeding and the parents' counseling and education. Akash. Moderate PA, admit to hospital, treat the underlying cause of problems. Again, diet, provide a reinforced milk diet and teach preparation of milk diet. So in case the mother cannot give her milk, then you have to give some artificial feed, and that is called milk diet. Okay. For it. Severe PM again, hospitalization, watch for complications. There are plenty of complications which can occur. Dietary treatment 4 gram per kg of protein. Marasmus 150 to 200 kilocalories. Kwashiorkor 100 kilocalories per kg per day. These are the standard treatment given. Then reinforced milk or high cereal milk should be given. Child should be fed with milk diet at a ratio of 125 milliliters per kg per day. And you should prevent hypoglycemia. So anytime the child can go to hypoglycemia, meaning blood sugar can drop. Nasogastric feeding, it's Ryle's tube feeding. Gradually increase the feed. You give a small bit now, little later you give slightly. If the child is able to tolerate, give a bit more. Don't give one shot, don't give. So schedule 8 feeds per day. Every 3 hours you can give feed. And the child should be able to tolerate it. Now suppose the child has diarrhea and the child is not able to tolerate, then there's a problem. So you have to ensure that the child is being given the food and is able to tolerate it. Supplemental minerals and vitamins and treat the infections. Okay. What are the complications? Plenty of complications are there. You can have dehydration, you can have shock, you can have systemic local infections, dyselectrolemia, particularly hyponatremia, hypokalemia, hypoglycemia, hypothermia. Hypoglycemia means sugars drop down. Hypothermia means the child has become suddenly cold. Lack of congestive cardiac failure, bleeding disorders, hepatic dysfunctions, liver problems, sudden infant death syndrome. This child suddenly dies with no cause. Then convulsions. Long term, the child can have cachexia, it means lean and thin. Growth retardation, mental abnormalities, visual and learning disabilities. So these are all a lot of complications there in PEM. If it's not treated properly, you have plenty of problems. Okay, so it's important that we treat PEM and restore the child to the normal health. Now we probably come almost to the last part. So just a few pictures. So we talk about weighing a child and all this stuff. So this is how the child is weighed in the health center by this spring balance. The child is put there. Up to 5 years, the child is put in a sort of cradle, and the ANM or Anganwadi worker, she's looking at this, or the Asha worker is looking at this. This is Anganwadi, by the way, and this they're noting down the weight of the child. Okay. Suppose there's a mother who's there's no weighing machine. I mean, the mother's having a baby in the arms. You want to check the weight of the baby. How will you check the weight of the baby? How will you check the weight of the baby if the baby is in the mother's arms and you don't have all this equipment? Yes? Huh? Yeah, you take the mother and child stand on a weighing machine, and then you take the mother only on the weighing machine. So you subtract the difference between that. That will give the weight of the child. Okay. Next. So this is how, if you have this thing, this becomes easy. This is called an infantometer. You place the child like that, and you push this to the, put the toes, put your hands on the knees, make the legs flat till it touches the tip of the foot end. Okay, so that is the length of the child. Okay, so and the head of the child should be at that level. Next. This is of course for adults. We have the stadiometer. You're taking the height, and if there's no stadiometer, what you do is you mark it here and you just put a tape. It should be erect. The person should stand straight, not looking down or looking up like that. And this should be measured. Okay, that is, we have it in our department. You can see it whenever you feel like. Next. Then you have what is called for assessing the mid-arm circumference. We have what is called a Shakir's tape. So if it is green, the color is green, it means it's all right. If it's red, it's malnourished. Yellow means it can be a problem case. So this is how the mid-arm circumference is taken. Next. So this is a mid-arm circumference tape. So if the child is if it goes in the red zone, that means the child is malnourished. Yellow could be a warning sign. Green is the child is okay, right? So that's called a Shakir's tape or mid-arm circumference tape. Next. Then you have bangle test. So if you put a bangle and there's a specific size of the bangle, if it passes through above the elbow, that means the child is malnourished. So normally a bangle would not go beyond this, but if the bangle goes up to here, if the bangle should have a certain size of 4 centimeters, then we consider this as a severe malnutrition. Okay, all right. So this is a growth chart. Now, it may not be visible, but if it's there in your books, ideally this is a growth chart for boys. So all the values should be between these two. Okay, green and yellow. Green means it's okay, yellow is all right. But once it goes here, there's a chance that this is malnutrition. So this is a weight for age birth to 5 years for boys. This is also called the road to health chart. Okay, road to health. So all weight should be fall within this group for it. And this is for now having taught this thing. Now tell me what is wrong with this thing. The growth can be tracked: normal, malnourished, severely malnourished. So here, what is happening in child number 1, child number 2, child number 3? Tell me, what is child 1? Child 1 is what? Huh? Child 1 is okay. What about child 2? When compared to child 1, what is the problem? What was child 2 as compared to child 1? And what is child 3 as compared to child 1? Child 2 is what? Child 2 is there's a wasting, right? You can see the ribs and all. Child 3, what is happening? Is it wasting or something else? What is the difference between child 1 and child 3? Child 3 is stunted. It's not having the same height. Okay. So that is why this is the normal thing. This is malnourished is yellow and red one is severely malnourished. Okay. So this is what is happening. Child 2 is malnourished, but child 3 is severely malnourished. This thing, just remember this. Now what is this? Yes, it is marasmus. Okay. Why? Because the child is looking like this and like an old man. You can count the ribs, the skin, and the child is given a drip and things like that. Next. Now this is the same thing of taking the weight in the Anganwadi center. Okay. For it. This is taking the height in the Anganwadi center. For it. This is Kwashiorkor. You have a pot belly. You can see the changes in the hair, but the child doesn't look that bad. The ribs are not counted, but there is edema. Abdomen is distended. So the Kwashiorkor and Marasmus, a big difference is edema. Okay, and Marasmus, the child has an old man look. Kwashiorkor, the child doesn't look that bad. Doesn't look like an old man. Of course, the hair changes are there for it. Okay, so the same picture again for it. So this is now what is happening now in the Anganwadis and health centers is this. The Anganwadi worker or the health staff, they are explaining to the people what all things to be taken. You don't need to take very rich food. Whatever is available, you can see the food materials which are put over there. Locally food material, just give that, the child will be alright. Okay, you don't have to order from Zomato or somewhere. Just with the basic food, healthy food which is locally available, you can treat malnutrition and you can prevent malnutrition. Okay, so it's not necessary that you have to bring a lot of cakes or this and that. Whatever is available in the local level, you can do it. This is the actual picture of the Anganwadi. Next. Now this is what we have this, nowadays we are having a lot of talk about this. Volunteers are working for nutrition, Jan Poshan Ahar. So they are talking about this, and this is a picture of the volunteers with the mother and child, and they are treating the thing. So basically malnutrition is still there, but it's not that much as it was in the past, and things have improved a lot because of various interventions from the Ministry of Health and from the Anganwadi side. We're getting good nutritious food and children are more or less okay. But still, as far as we are still concerned, we still have wasting. About 20% wasting is still there, and that is due to various pockets have got their own thing. For example, a tribal area may be having a different setup than some other place, or some hard to reach area where the Anganwadi workers are finding it difficult to enter for some reason.